Welcome to MD Source, helping you become a more informed you when it comes to your health. With a mission to share the most accurate and up-to-date medical advice and tips for healthy living, MD Source has conversations with real doctors and medical professionals who are the experts on the topics you want to know about. Today's special guest is Dr. Erez Dayan, one of the country's foremost experts on migraines and migraine surgery. And now, here's Dr. Rod Rourke.
Erez, welcome. It's good. We're very pleased to have Erez Dayan with us, who's an expert in migraine surgery. He's a Harvard-trained plastic surgeon, and has a forthcoming book on migraines for the consumers. So we're excited to hear that. It's going to be coming out fairly soon, right?
Yes, thank you very much, Dr. Rourke.
So tell us a little bit about yourself and how you got interested in migraine headaches as a plastic surgeon.
Yeah, so it was a little bit of a serendipitous occurrence, really. When I was training in Boston at Mass General Hospital, our chairman there, Dr. J. Austin, was really becoming interested in migraine surgery. And most people wouldn't think that migraine surgery has anything to do with plastic surgery. It's just
right.
Those two fields just don't seem to connect, but really they're very connected because plastic surgeons are intimately involved with the anatomy of nerves, and there's a peripheral nerve theory thinking that compression or scar tissue around certain nerves in different areas of the head and neck can cause migraines. And since that theory has been studied and shown, plastic surgeons have become more involved in treating migraines through surgery.
Yeah. So how many millions of people have migraines in the United States?
So migraines are actually extremely common. Over 39 million Americans suffer from it. Yeah, it's very prevalent, and it's really a big issue, particularly for females. Mostly it's women that are affected by migraines, and it's really people in their kind of prime of their lives, in their 20s and their 30s. It costs our healthcare system a lot of money in terms of ED visits, missed days of work, so it's really a very significant problem.
So how do you know, 39 million, that's a lot. Wow. So how do you know you have a migraine? So if a patient says, I'm going to look up on Dr. Google, I think I have a migraine. What are some of the key points, Erez?
Yeah, so it's actually a very good point because to diagnose migraines in and of itself can be challenging. There's multiple different types of headaches, tension headaches, cluster headaches, and then migraines. And for people even neurologists to differentiate those things can be challenging. So really, a migraine is defined as an episodic neurologic disorder where you get a severe pulsating headache.
And it can be anywhere.
Can be anywhere.
Okay.
And it can start anywhere. And part of migraine surgery is identifying where those trigger points are to know where to treat them and how many trigger points there are. But a lot of patients, about 25%, have an aura prior to the migraine surgery. So there may be things that trigger the migraine surgery. You may...
like what's an aura? Like I have a vision?
So for example, about 25% of migraine patients will have some kind of visual change, some auditory change, some somatosensory change. They may smell something prior to the migraine coming on.
And they say, aha, that's my migraine.
Correct.
Okay.
Correct. And actually, that's a big part of the reason why many people with migraines, you'll find them in a dark room, kind of in a place where there's not a lot of stimulation. The unfortunate thing is stress is a big trigger for migraines.
Right.
And just the episodic nature of the migraine can cause people to be stressed to the point that it will trigger a migraine. So it's really a very almost vicious cycle.
So that's 25%. So what are the other common things in a migraine?
So severe pulsating headache, particularly for people that have, for example, trigger sites. The most common trigger site is in the glabellar area, right in the inner part of the eyebrow, in the forehead, between the eyebrows. They'll start feeling a pain there, and then it kind of travels towards the back of the head. That's a very common presentation that we see. And luckily now, since the early 2000s, we've found ways to treat those trigger sites.
And that's a very common presentation?
Yes, that's among the most common.
That's the most common,
yes.
Which is, of course, why potentially, and we'll talk a little bit about migraine surgery.
Right.
So you mentioned a little bit about the prevalence. Is it really 39 million? And how many of those are women?
So 35 million and 25% of those are women, and those are typically people between the ages of 20 and 60. Those are the people that really report severe headaches or migraine headaches within about 3 months. So women are definitely disproportionately represented in this group. And it really affects their quality of life to the point that they can't go to work, and they're seeing doctors in the emergency room.
Is it hormone related or what?
Yeah, so there are definitely correlations between hormones. There's a lot that's not completely known about migraines, but it's certainly even just the pathophysiology is now being sorted out. As you know, there's a lot of debate between neurologists and surgeons. Many neurologists don't believe that migraine surgery is a valid treatment, but we've seen in a number of studies, including randomized studies and placebo studies, that actually migraine surgery has shown to have a significant impact on patients.
Well, let's talk about that. And this quote about in your upcoming book is that migraine is the sixth most debilitating disease in the world.
Right.
And is the seventh leading cause of years lived with disability in the U.S. That's amazing. So talk about, you're a plastic surgeon. So what are the treatment options? Obviously, we don't jump to surgery. So
Right.
How does a patient know when they're a non-surgical candidate or a surgical candidate?
So, the way we've treated it, and we've been very conservative, is first, the patients have to be followed by a neurologist. That's the standard of care. And any kind of triggering point, different patients have different triggers, should clearly be avoided. And a lot of it is really lifestyle changes. Perhaps patients are sensitive to bright lights, so they shouldn't be in environments that would trigger their migraines. There are a lot of medical therapies that are actually very effective for people with migraines, and really surgery is reserved for patients that are refractory.
So what percent are refractory, would you say?
It's hard to know an exact number, but probably something around 10-15%. So it's a high number.
It's a high number.
It's a very high number.
10-15% of 39 million is a lot.
Yes. And actually, the way that we've looked at that is there are different scoring. There are different scoring mechanisms. The MIDAS score is one. The International Headache Society has its own classification of disorders, and really the patients that are eligible for migraine surgery fall far off the chart in terms of their migraine severity score. So what we look at is how many migraines they've had in the past 3 months, how many days off of work it's caused, really what's the impact on their quality of life, and based on that we decide if surgery is
So these are
an
the
option.
extreme cases. They're refractory
Correct.
to medical therapy. They keep recurring.
Right.
Medicines don't work, and everybody's
Right.
scratching their head.
Exactly. And part of the problem with these medications are they're not benign. A lot of these medications have significant side effects. Patients sometimes have a harder time managing the side effects than the migraines when you're looking at triptans and different kind of medications for migraines. So we're really in a challenging place because this does affect so many millions of people, but we really don't have a great solution.
So you see these patients that you mentioned, and they've got refractory headaches. Medicine hasn't worked. They've seen 3 neurologists, and they come to you. So how do you determine whether they're a candidate that can be helped by what you're doing?
So what we did, at least in the Harvard system, and many people are doing this, is first we evaluate them based on their symptoms. We look at how often, how severe, and what kind of impact it's having on their lives. And we get an index score of how much they're debilitated by this condition. We're in discussion with their neurologist, see what treatments they've had already. And then what we do is we have an image of one's head, and we ask them, draw an X over where the migraine starts, and then draw an arrow to where it travels.
So it's just a picture of their head?
Just a picture. So we just show a picture, and typically it's very interesting. They actually, they didn't read the anatomy book, but they follow the anatomy. So they'll say, I feel it start right between my eyebrows, and they'll draw an X there, and then they'll draw an arrow going towards the back of their head.
Really, like going back?
Yeah, just like that. And it's amazing. Or sometimes they'll show the X at the back of their head.
The trigger point
there, and then they'll show the arrow moving forward. So it's kind of amazing. And it's something that Dr. Jay Austin and Lisa Geffer, one of his postdoctorate fellows, came up with. And it was actually, the simplicity of it was brilliant because...
Plus everybody can see it, and the patient says, aha.
Yeah.
And also when you treat it, they say, it's gone.
It's amazing. There are only a certain number of trigger points, and the patients can really identify those. So once we identify that this is a patient that's very debilitated and can benefit from potential surgery, there are a number of things we can do before surgery to see how they may react. And those things include local anesthesia block, so we can block those peripheral nerves.
The trigger points?
The trigger points, exactly. So if the patient says, I have pain right in between my eyebrows, we would inject that area with either Botox or local anesthesia. And it's pretty incredible when you inject them with local anesthesia, particularly if they're in the middle of a migraine.
It'll stop it?
It'll stop within 10 or 15 minutes.
Really?
Yes.
So how does Botox work? We hear about all these things about Botox is a cure for migraines. And I know that actually it's great for stress headaches that I use on all my cosmetic patients, and even some from Botox. So how does that work? And Is that a diagnostic tool for you too, for surgery?
Yes, absolutely. So Botox has actually been extremely useful for us in terms of a diagnostic tool. And the main reason for that is we know now that these sensory nerves travel through muscles. And actually, this is how migraine surgery came up. There was a surgeon, Dr. Guyron, who was noticing doing aesthetic surgery that when he would remove or weaken certain muscles, a certain percentage of those patients didn't have migraines. So what you can do with Botox is you weaken or essentially make those muscles inactive. And when you do that, the nerve becomes less compressed. And that kind of allows you to stimulate what it may be like after surgery.
So if Botox works, but that takes 7 to 10 days, doesn't it? I mean,
Yes. Right.
And the local anesthesia is positive, then they're good candidates?
Typically, yes. So if you do a local anesthesia block and then do Botox, and both of those things have typically it's a very clear effect for the patient. It's not really questionable. Either they feel a significant difference or they don't. And if they do feel a significant difference, the correlation with success after surgery is very high. It's over 90%.
Really?
Yes.
What percent of those patients that are treated with Botox, I mean, where does it help? I hear it's 50, 70% or?
Well, it depends. I mean, I think if the patient comes with a very clear idea of where the trigger point is, it's a high percentage. And interestingly, what we've learned is that about 5 to 10% of patients have more than one trigger site. So if you block one trigger site, that's a major trigger site, a lot of times there can be a second trigger site.
So it's a high percentage?
It's a high percentage.
So how do you elucidate that if they just drew one trigger point?
It's a challenge because typically one trigger point is dominant. And if you block that trigger point, then the secondary trigger point may become dominant. There's something about patients with refractory migraine surgery that just causes them to be more apt to being irritated from these central...
What percent is that? That's quite a few?
It's many people. And we learned that because when we were doing surgery on major trigger points, there was still a percentage of people that would come back and say, well, now I feel it coming from a different place. So it's definitely a field that's evolving. And we're learning.
So how do you get to all of them in one surgery? So you have to kind of do the local and then see where the next one
Correct.
comes
So
from?
typically we would do a local block, see how the patient responds, and if they have a secondary trigger point, we would take that into account. Oftentimes these trigger points can be dealt with in the same operation.
So what are the most common types of trigger points? So I know you mentioned the forehead and the trigger points in the back of the head.
Right. So there's major trigger points and minor trigger points. The major trigger points are between the eyebrows. That's the glabellar area. And those nerves are called supraorbital, supratrochlear nerves. There's one in the back of the head, right behind. All of us have a bump there. It's called a protuberance, occipital protuberance. And there are larger nerves there that travel through our neck muscles. And that's a major trigger point as well. And there's about 9 or 10 different compression spots that could be released along the track of that nerve. And then there's a trigger point in the nasal area. It's a rhinogenic trigger point, and it's very classic. Patients with that trigger point have pain behind the eyes on both sides.
And where is it on the nose?
It's really deep in the nose, but patients say they feel it kind of centrally. They think a lot of times it's a sinus.
Is it like
headache.
Deep near the septum?
Correct, exactly. And actually many times we refer to our ENT colleagues because a lot of these patients do have deviated septums or have ENT issues that they need to be worked out as well. And a lot of times when you get imaging on them, it's amazing that you can actually see a lot of the pathology in person.
You've determined all the trigger points and now you're ready for surgery. So tell us about the surgery. Is it a big deal? How long does it take?
So it's actually not, any surgery we consider to be major surgery, but it's relatively safe. We haven't had any major complications from any of these kind of operations. And depending on the trigger point, it usually takes, 1.5 to 2.5 hours.
It's day surgery?
Day surgery. They come in, they go home the same day. Relatively painless. We inject local anesthesia. Essentially what we do is we identify where the nerve is. We release areas around it. Oftentimes we'll take what we call a pedicle of fat, which is just an area of fat that we kind of wrap around the released nerve to cushion it so that it doesn't develop any new scar tissue around it. And patients often seem to do very well once they're properly selected.
So it's minimally invasive, small incisions in your hairline, like for the forehead, they're done up here in the back. Yeah,
exactly. It can be done endoscopically. It is often done, if not endoscopically, through a very cosmetic, actually the same incision you would use for a blepharoplasty, for aesthetic treatment of the upper eyelid. So it's a very aesthetic operation in terms of scars.
what's the recovery like from this procedure, Erez?
Yeah, so most patients do well. They are discharged the same day. They come back 1 week after for follow-up. Really, all the sutures that we use are typically absorbable, so there's no need to take out stitches. We don't really use drains. Sometimes we'll put one small drain in for the back.
How do I know it's successful? What do you tell your patients? What's the end point?
So really, after the surgery, most people, if that was the correctly identified trigger point, they should not have a migraine from that trigger point again, because that nerve is released, it's cushioned, and typically it's really, patients are very grateful. Many people hesitated to operate on patients with migraines because they felt that, well, what if we don't treat them? They're going to come back more upset, and there was a whole concern.
Right. Because these people are kind of the end of the line, and
absolutely,
medicine hasn't worked. They're upset at all of their different neurologists.
And you can imagine this is a scary field to enter, because you have patients that are really debilitated, they're upset,
right.
And the last thing you want to do is potentially operate on a patient that's starting off in a bad place.
Because this goes against that axiom in surgery that when you operate on pain, you get pain.
Right,
so
exactly.
this must be the exception
Yes.
where with migraine surgery, you actually cure pain.
Yes.
So basically, if I can summarize, you're identifying these trigger points, you're releasing them with small incisions, you're releasing the muscle or the constriction, you're adding fat as a buffer, a cushion,
Right.
and then they'll literally have a high cure rate. What percent do you tell your patients?
The literature has shown, looking at a number of different studies, it's somewhere, if the patient is properly selected, above 90%.
Above 90%?
It's very high. It's very high, and almost it's surprisingly high, because usually there are very few things you do that have that high of a success rate.
So why are the neurologists not kind of upset at us for this? And what is it? Tell us. I don't understand that.
So I think there's because this area is evolving, there's a lot of philosophical ideas about the pathophysiology of migraines and different thoughts about how it should be best treated. And a lot of it comes from what angle we're coming from. It's all about your viewpoint. And for plastic surgeons, we take a surgical viewpoint and we look at the peripheral nerves, and we've seen that it's made a difference.
But this is exactly where, if two specialties that are very good at what they're doing work together, don't you think it's all about the patient's outcome?
Absolutely, absolutely. And actually, a big part of the reason we put this book together was two reasons. Number one was to educate patients, because unfortunately, in many areas of medicine, the patient really only knows what their doctor tells them. And it's such a debilitating problem that affects so many people. It's important to get the information, just the data. And really, the book talks about medical treatment, it talks about surgical treatment, and it gives you kind of a simple overview of migraine treatment and migraine etiology in general. So that was the goal of the book, and I think...
So tell me, Erez, so what's the future for migraine surgery? Is it going to be expanded for other areas, or where do you see it going?
I think it's already been expanding rapidly since the early 2000s. Most cities have migraine surgeons there. We're looking more and more at the pathophysiology, the histology of these nerves. I can say, in the Harvard system at Mass General, they're taking samples of nerves, and they probably have the largest collection of them to study and see what's different about those particular nerves. The other thing is, we're looking at the anatomy. What are the different anatomic variations of how these nerves are traveling? What percentage of them travel through bone? What percentage of them travel through muscle?
Wow. To summarize, so you have 39 million people in the United States. A lot of them are women in the prime of their lives, and they have these debilitating symptoms related to migraines that actually aren't treated with medicine. This new cure can potentially, if diagnosed correctly, in a short operative procedure, have a high percent of patients, 90+% that can be cured and transform their lives. So Erez, when is your book going to be coming out, and how do people get this?
Well, we've been working hard on it. It's just in the final stages of layout and just some illustrations. So it should be out in the next week or two. We're hoping probably late September. And it's going to be on Amazon. We wanted to make it most easily accessible to patients. So there's going to be an ebook copy that's available, an audio book if you wanted to listen to it, and then obviously a hard copy. And the goal is really just to get the information out. Right. That's the name of the game.
It's phenomenal, and I think and that's why MD Source is really appreciative to you because basically, the best care comes from a better informed you.
Yes.
And this has been fascinating. And I had no idea that it touched so many lives, so many millions of people's lives. So thank you so much, Erez.
Thank you. Thank you for having me,
You
Dr.
bet.
Rourke. Thank you.
From the team at MD Source, here's to good health and to helping you become a more informed you. For the latest and most up-to-date information on health topics, visit mdsource.com. Drop us a line, sign up for our newsletter, and connect with us at mdsource.com.